that we are still going to be able to practice on. And then we've got one clinic where we are going to be talking about OHE and how to approach OHE with your patients. Now, having said that, there are a lot of clinic help videos and those type of things already posted on Canvas. Now, you can use videos also in your OHE book, and you can have things saved to the desktop. You can have a USB that you put in for OHE. And that's fine too, that have some good videos. So you have some sort of animation going on, but we don't want you to just use that animation. This is a dialogue between you and your patient. So I've posted things in English. I've got some Spanish references there as well for toothbrush, flossing, that type of thing. So investigate what the internet has to help you, because I can tell you a patient is ever so grateful if you can try and communicate in their own language, even though they have a good command of English. Sometimes it's just nice to be able to have them hear their own language. So I do have a section for toothbrush instructions and all that other stuff that we're going to be going over during that one clinic. So we've got a clinic devoted to how are you going to do this? How are you going to approach it? These are the various techniques that we're going to be talking about today, and that's in this chapter on. I've got the wrong chapter up. Interdental care. So I can't do two things at once, obviously. So we're going to be talking about all of that and showing you with models, and you're going to be working on your partner as well. '27 and 27. I don't know why I've got both 27s up. Okay, so give me a second here. Okay, do I have chapter 26 up?
Yes, but it looks like it's your desktop.
Oh, geez. It's okay. 27. Aren't you glad you don't have to come to campus today?
I'm not sad about it, but I was only supposed to be the patient, so I'm not really missing out on anything.
Okay, now do I have chapter 26 up?
Yes.
So yes, you can work on your OHE book. There you go. Oop. Okay, toothbrushing is also called oral infection control, because we know that gingivitis and oral disease is an infection. Now, is it a contagious infection? or does it just stay in your mouth? Can you transmit it?
It's contagious.
It's contagious. This is transmittable. Exactly. Periodontal disease, the bugs that are responsible for periodontal disease, as well as the bugs responsible for dental caries, cavities, is transmissible. So it's important that we try and change our language to have the patients that we're trying to educate understand that this is an infection in their mouth and that it is controllable and it is transmissible. So one of the things that we do for oral infection control is to use a toothbrush or some sort of tooth cleaning thing. And it doesn't always have to be a toothbrush, because it always hasn't been a toothbrush. And in some countries, it's still not a toothbrush as far as what is the most popular. But as long as you're disrupting those microbes, you're good. But it's the personal oral health care plan for prevention interventions that's determined for each patient's oral health needs, dental caries risks, periodontal infection risk factors, and patient's ability to perform self-care procedures. Okay, so that's directly out of the book. We do that for every patient, but what we do is we individualize it for every patient. So our sequence oftentimes is the same, but our emphasis might be different. Johnny is 15 and is drinking Red Bull and eating high carbohydrate snacks all the time. So he's got gingivitis, but he's also at a greater caries risk because of that onslaught of fermentable carbohydrates, versus somebody else might have a dry mouth and is older with root surfaces exposed. They are also at a high caries risk because of their circumstances, but their approach might be very different. So you're the dental hygienist, and we have that ethical obligation to really review what the current research is saying and select the appropriate interventions for that particular patient. So that is where the human needs model is supposed to come in as well, because you've done your caries risk, you've done your EOIO, and you're getting ready to, you've done your perio assessment, you're getting ready to develop your treatment plan. What are the highlights of that assessment that you need to really concentrate on? Because that is going to be different for each and every person. So the objective for you is to teach and motivate each patient. And my daughter's calling me. Okay. Personal daily care. Okay. You've got to do everything every 24 hours. If the bacteria is not disrupted within 24 hours, it's going to do bad stuff. And to use dental floss to remove biofilm from the proximal surfaces and any debris that's collected in the interproximal spaces. So the book is saying dental floss, but what is the research saying? Research right now is indicating that floss is not the only thing you can use to disrupt that interproximal biofilm. Research is also saying, and this is what the next chapter is going to be on, that floss sometimes is a waste of time for our patients. So instead of berating them or saying you've got to use dental floss, maybe you could use a water flosser or a water pick, or maybe this little brush that can go in between your teeth is going to be much more effective, right? But you want to see what the science is and let science drive you. And that's why you're doing a literature review this semester. That's why you looked at a study last semester. It doesn't stop. So flossing before brushing, okay? And that's how I learned it too. You want to floss before brushing, allows access of the proximal tooth surfaces as well as the interdental gingiva to fluoride. When I was in school, you had to have a biofilm or plaque-free surface. It wasn't called biofilm then. You needed a plaque-free surface for the fluoride to interact. So we had to floss first. Well, now they're even finding that a little bit of biofilm might be beneficial because that fluoride gets absorbed and housed in that biofilm. So you have a little bit longer surface time with that fluoride. So toothbrushing follows flossing to remove the biofilm. That's still pretty much the same now as it was 40 years ago. But the whole idea is, do you, because patients are going to be asking you, do you have to brush and floss at the same time? And what's your answer to that right now? Is it important that you do the two at the same time? And my answer is no, it isn't, because as long as you're getting in there every 24 hours to disrupt all of those microbes, you're good. So you could be brushing morning and evening and flossing after lunch. You could be flossing in the car. You could, it doesn't have to be all at the same time. So if the patient can't commit to be in the bathroom to do all of this at once, split it up. We have some patients that will brush in the shower or floss in the shower. And that's fine too. So you're brushing, you're flossing, you are cleaning the tongue. Tongue hygiene, it has always been important, but now they are realizing that that's where a lot of the stuff is housed, because we've got a shag carpet for a tongue. We've got all these papillas. It's got nooks and crannies, and bacteria likes to house in there, as well as dead skin cells. So the toothbrush right now has been the principal instrument for what we use for general care. Most patients will brush almost every day. Some will say they brush twice a day. Some will say they brush 3 times a day. Some will say they brush every day, and they're lying. Then you're asking them how long do they spend when they're brushing. 2 minutes. And it's really, the studies are showing that it's like much less than that. But patients who have not previously received professional advice concerning the best brush for their particular oral conditions are going to be looking at you for what's the best brush. It's not just one toothbrush out there anymore. You go into the oral hygiene aisle at any store and it is overwhelming. And the more you know about retail and shelf space, those that have the most money are going to have things, the companies with the most money or spending the most money are going to have things at eye level. The less expensive, less popular items are going to be up or going to be down. Are they just as effective? Don't know. But it's important that you go through these aisles, because this is what your patient is going to be asking you about. So you want to know what their habits are. You also want to know what their family tradition is. Where is oral hygiene on the realm of what's important to them? And it could just be that an awareness. It could be a financial thing, that they don't have brushes available to them, or toothpaste, or they don't have that dental IQ. And what we found with treating the low socioeconomic status kids is that we give Johnny a toothbrush because we're doing some sort of a program at a school, but their siblings don't have a brush either, or their parents don't have a brush. So it's important that the whole family has access to these. So let's talk a little bit about the history of toothbrushes. Occasionally there's one board question that has to do with the history of toothbrushes. So it's all part of being that well-rounded professional. But there are crudely contrived toothpicks. Some of them look like they were specifically designed. They're frayed edges that have been believed to be the earliest implements to help clean the teeth. So there's always been dental work going on from the beginning of mankind. Excavations of certain populations show elaborate gold toothpicks were used as early as 3000 BC. There are chew sticks that are still being used today, but that's considered to be a primitive toothpick or a toothbrush, and that's a certain type of soft stick with flayed edges. 1600 BC, a miswak or a seawalk chew sticks are still being used today, and I have one at clinic, so when we're going through our oral hygiene we can pass that around if you've never seen one. So oral health care has been, again, with us since we've realized teeth are in our mouth. Plus teeth break and they hurt, so that puts an emphasis for that particular person that something's going on and something might need to be done. But the first believed brush was actually made out of hog's bristles, and that was mentioned in Chinese literature. And then there was in 1728 something in France where horsehair was not being recommended because it was rough and destructive. The thing with the natural bristle brushes, especially the boar's hair and everything, is that hair has a lumen. It's got a tiny little tube and bacteria is housed there, and it's very difficult to have soft, medium, firm bristle consistency from one brush to the other. So just kind of review that. Nylon is now what's being used mostly. With ecology, we're getting now into also bamboo, eucalyptus, and other products that are sustainable and that can break down in our landfills, because nylon, once it's in the landfill, is always going to be there. So who knows what another 20 years is going to bring for you all. But historically, the purpose of brushing was to provide a massage to the gum tissue. And massage or friction from that hard bristle brush was believed to increase keratinization, which in turn would result in resistance to infection. So hard bristle brushes, big hard bristle brushes, if it hurt, it was good. And this is how science learns too, because after a while, years later, we scratch our head and go, there aren't any gum tissues around these people's teeth. I wonder why. I wonder if the toothbrush is causing damage. This is how we learn. So manual toothbrushes have been around since the beginning of time. We want to make sure that the toothbrush conforms to the individual patient needs, because there are so many toothbrushes, like I said, out there. And this is the classic toothbrush. Just like your instruments that you have, there are parts: the handle, the shank, and the head. So you can see with this one, this has a level brushing plane, the classic toothbrush. You don't see very many like that anymore. You want the handle to be large enough to be able to grip. You want some sort of texturing. What is the texturing called on your instrument handles?
Knurling.
Knurling, exactly. Because if your hands get wet, you don't want them slipping. You want a shank here to be able to get better access. You want a narrow width so it can reach the back area where your cheeks are tight. And you want a rounded head as well, so you're not poking. The toothbrush length is about 15 to 19 centimeters. That's 6 to 7.5 inches long. The junior and pedo brushes are a little bit smaller. The head needs to be large enough to accommodate the tufts, and each bundle of bristles is a tuft. Okay, it's not one bristle, you've got tufts. The length of the brushing plane, again, typically the smaller the better. But what is on test questions, my friends, are the bristle or filament height. That's 11 millimeters or 7/16 of an inch. Okay, the longer the bristles, the more flexible and the softer the bristles feel. So you could have a soft brush that has all of the characteristics of a soft brush, but if it has shorter filaments, it's going to appear firmer to the patient versus somebody that's using something with longer filaments, it's going to appear softer. All right, so the bristle filament height, 11 millimeters. Handles are usually made out of plastic right now, but we're getting into more sustainable products. And there are all sorts of different styles. We want to be able to effectively disrupt bacteria, remove bacteria, massage the tissue, clean underneath the tissue into that sulcus area without creating damage, but while stimulating the gingiva at the same time. So this is just some of the things that are out there right now. Okay. The classic is the top, the flat. Then Crest came out with these rippled, which is supposed to get in between the teeth better because our teeth are not flat. Butler has a good brush out with these tiny little filaments, and Oral-B has one now as well that has these thin filaments that massage and get tickled underneath the gum tissue. Then you've got these multi-level bristles. These are supposed to, the higher brush bristles here are supposed to be able to wrap around the terminal molars and get those mandibular anterior and maxillary anterior linguals better. Then they came up with these multi-angled brushes, and they sometimes have little rubber attachments to them for more stimulation. Again, the whole science is how much bacteria can these brushes remove and what's best for the patient. And then there's this bi-level orthodontic brush that's kind of scooped out here in the center. So the actual bracket would be fitting in here so the brush can go on top and underneath the bracket. And there's many more out there. So patients are going to ask, what's the best brush for me? You have toothbrushes that are in your kit, and they're Oral-B. I bought these things for you, or I ordered them by price as well as popularity. So you've got standard brushes. You're going to be getting Johnson & Johnson Reach toothbrushes next year when you're a second-year student, because we are our school is in a study with Johnson & Johnson. So they're going to be providing different brushes for you as well. So you'll get a feel for some of these. It's also good for you to go out and buy these yourself so you can see what is out on the market and you have firsthand knowledge. That's why when you get your Sonicare, that's why when you get your Oral-B, those companies want you using them so you've got firsthand knowledge. So when you get these things from companies, don't give them away, use them, and then you can give them away. But what's best for the patient? And do they have big teeth, little teeth? Do they have crowding? You're going to have to make that determination. With the plastic filaments, when they first came out, and the cheap brushes are just chopped off and you don't have rounded edges. So toothbrush companies are now saying, especially Oral-B, they've got these rounded filaments because you're not going to be jabbing the gum tissue. So you want to be looking for those rounded filaments. The natural brush hairs looked like this, plus bacteria would get right down in the center here. Less trauma to the tissue, more massage and stimulation. Okay, so everybody's had experience with the manual brush. Now, do you all, have you gotten your Sonicares? We haven't done Sonicare yet, have we?
No.
No, okay. That's something that I will try and get together this semester. They've revamped their districts, and she's trying to get both first and second year together. So it's scheduling is a nightmare. But we're getting into power brushes. Does everybody need a power brush? Patients are going to ask, do I need an electric brush? What do you tell them? Well, it all depends. Are you a gadget person? If they've got great oral hygiene and a healthy mouth, they don't need a power brush. But if they're not flossing, if they have special needs inside their mouth for whatever reason, a power brush might be better for them. So again, not everybody needs a power brush. What is the science saying? But the science is saying it can be more effective if used properly. And that's always the case, if used properly. So that's important also to have samples of these brushes in the clinic or in your office so you can show the patient directly what's going on and how to use them. We are getting away from showing inside the mouth because of aerosols with COVID, but you can show them, it's not as effective, but you can show them on a model. Pause, 1, 2, 3, pause, 1, 2, 3. They're not moving it like a regular brush. So the technique is different, and it's different than when you're using an Oral-B versus when you're using a Sonicare or one of the other brushes. But they can be very effective, especially for patients that can't do a thorough job of using the manual brush. So you need to know before you even start your OHE with your patient, what are they using? Are you using a manual brush? Or are you using a powered brush? I can't tell you how many skill evaluations I sit with as well as other faculty. And you're going through all of the spiel and you're going through your clinic, your OHE book and brushing. And then I ask the patient, well, what brush are you using? And they're saying, oh, I have an electric one. Well, if you know they're using an electric one from the beginning, you can tailor your OHE, oral hygiene education, to whatever brush that they're using. And we do have the Oral-B plugged in so you can show them either in their mouth or on a model on how to use it. But their motions are different. Some go up and down, some go back and forth. Some are round brushes, some are look like a regular toothbrush, some are rechargeable batteries, some only have, the less expensive ones only have a battery itself, and you either originally would throw the whole thing out or you'd have a replaceable battery. But these are just some of the types that you'll see with the powered brush. This is one of the first toothbrushes, power brushes that came out probably about 35 years ago that changed how the dental profession is looking at power brushes. Before that, we were going, it's just an electric toothbrush. You're better off using a manual brush. This was called the Interplaque brush, and you had tufts of bristles, and each of these tufts were on had a little gear, and while one gear would go one way, the other gear would go the other. So this would go This would go this way, and this one would go this way, and you got really good scrubbing action. Long, long filaments. So it was like a nice scrub brush that would get in between the teeth. So periodontists, and I was working in perio, periodontists loved this brush because with gum recession, gingival recession, open embrasure spaces, these would just flop right on in there very nicely than a densely packed toothbrush. So depending on the make of the brush, this is the Oral-B. Okay, child power brush profile. Look at it. It's just a little bit shorter than the adult brush because they've got a smaller mouth. Okay, and they usually have less power to it. You can see that the tufts are not as densely packed, so the bristles are going to appear to be more flexible. So patients, again, are going to be asking you, what is the best toothbrush for me? So you need to take into account their, do they have arthritis? What do you ask on your medical history if they circle arthritis? You ask where? Is it in their hands? Is it going to interrupt what you want them to be doing to take care of their teeth? If it's in their hands and they can't grip or they can't use floss effectively manually, you haven't even seen the patient yet inside their mouth, but you've done their oral, you've done their caries risk assessment. You're already coming up with alternatives for that particular patient. What's the state of their gingiva? Is there, do they have hyperkeratotic gingiva, gingival overgrowth? Is there recession? How friable, fragile is it? What's the positioning of the teeth? If they have crowding, say on those mandibular anteriors, they're going to need a smaller brush to get into those spaces. What's the patient's compliance? I'm only going to brush once a day and that's it. Well, if you're only going to brush once a day, you need to get them to be as effective as possible for that one time a day. So maybe a power brush is going to be better for that individual. So you've got to be taking into a lot of considerations. I am an Oral-B person. I love my Oral-B. I've been using Oral-B forever, my power brush. Do I have a Sonicare? Yes. I started out with the inner plaque. Didn't like it. It was too big for me. Don't like the sound of the Sonicare. Don't like the feel of the Sonicare. I got these tiny little square teeth. The Oral-B fits my mouth perfectly. But do I recommend the Sonicare for some patients? Absolutely. Absolutely. Depending on the patient and what's going on inside their mouth. So you're taking a look at all of this, and the stiffness of the filaments or the bristles is something that is an individual thing. We are only recommending soft bristle brushes to patients right now. Oral-B will only sell soft bristle brushes to dental offices. But guess what? Oral-B makes a medium textured toothbrush. They sell them. CVS, Walgreens, you can find them because that's what the patients want. So if you're having a patient that wants a hard bristle brush and you're trying to get them to use a softer bristle brush, you don't want something that has these really long filaments and lots of flexibility to them. You want a brush that's going to be a little more compact with shorter filaments to give that impression that it's still a firmer toothbrush, even though it's within that soft range. So we need to know about different brushing techniques. We need the language of what we're talking about. So when we're writing up our charts, we are all talking about the same thing. Toothbrushing, TBI, toothbrush instruction. Well, that's nice, but what did you show them? Because there's lots of different toothbrushes out there and toothbrush techniques. So we have to be as specific as possible. We need to state what the patient is doing. They're doing a scrub brush, or they're doing this or doing that, and what you demonstrated for them, so that when you see them the next time, or when the next hygienist sees them, they have a full understanding of, they were scrubbing before, you showed them the Bass or the modified Bass or the Stillmans or modified whatever, and you can see if that's working for them or not, and then modify techniques. But sulcular brushing, okay, these are the different methods. Sulcular, is sulcular good? Do we want to get underneath the gum tissue with our toothbrush? Yes or no?
Yes.
Yes, yes. You want to get into that sulcus. So look at this, the sulcular brushing method, the only one that's listed is Bass. The only one that's considered a sulcular brushing technique is Bass. So when you're just teaching a modified Stillman's brushing technique, are you showing the patient how to get into that sulcus? No. But there's something called a rolling technique, which is a rolling stroke or modified Stillman, a vibratory technique, which is the Stillman's here, Charters, or Bass, and modified Bass here. So we've got modified Stillman and modified Bass. Horizontal or scrubbing, that's what most people do. They just scrub, scrub, scrub. Circular is the Fones, and vertical is the Leonard technique. So this is what you need to know. This is what your test is going to be on. This is what you're going to review for your board exams, because they will be asking you questions on this as well. You're never going to get away from that. So the Bass and modified Bass technique, okay, is the sulcular brushing technique. You want to be able to direct the filament tips into the sulcus, okay, which is why it's a sulcular brushing technique. And it's widely accepted, this Bass method, as an effective method for removing the dental biofilm directly underneath the gingival margins. So this is good for all patients except post-surgery. If they've just had periodontal surgery, you don't want them doing this. It's good for patients who have had previous periodontal surgery. It's great for adapting around gingival margins. But with this, you're going to direct the filaments apically. So that's up for the maxillary and down for the mandibular, apically. And you position the filaments parallel to the long axis of the tooth. Okay, let me here. Parallel to the long axis of the tooth, all right? And then you angle it, and what you're doing is you're bringing this down just a little bit, and you're shimmying, you're making tiny little wiggles or vibrating, trying to get those bristles of the brush underneath into the sulcus. So they've got two different toothbrushes here. This is a Butler brush. I never liked this one. And look, what is it? What are these things here? That is a little, like a rubber mat that have these tiny little nubs on them, and that's supposed to be a tongue cleaner. It's the most ineffective tongue cleaner I've ever seen. But you can see that they're angling towards the gums, and then they're making tiny little wiggles. They're not moving off the teeth. It's only about half of a tooth width. Tiny wiggles back and forth, trying to shimmy those bristles underneath the gum tissue. And then for the anterior teeth, you're holding the brush parallel this way and doing one tooth at a time. With the Bass and the modified Bass, they're wiggling for a count of 10. Okay, wiggle, 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 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. That's the Bass. The modified Bass is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, sweep. They do a roll. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, sweep. And they do a roll. Then you've got your Stillmans and your modified Stillmans. So with this, for the Stillmans, look at how they're starting to place the bristles here, okay? It's completely against the gingiva. Then they roll it into position similar to what the bass would be. Then you do your wiggles. All right, and that's the Stillmans, your little vibrating for a count of 10, and then the roll. And that roll is the modified Stillmans when you're incorporating the roll. So this is the roll to get the rest of the tooth, because this is just concentrating on stimulating the gingiva. And look at the difference in the placement for this anterior. You're up on the gingiva and brushing the tooth this way. It's not designed to get into the sulcus. Can you see where this is designed to get into the sulcus? Placement of the brush.
Miss D,
Yeah,
so did you say the Stillman's method is not sulcular?
the Stillman's is not sulcular.
Okay,
It's what most students like teaching.
okay. The book says it's sulcular. I'm not sure though.
It's not the classic sulcular.
Okay.
So, because it's not designed to get up there, okay? It's designed to be massaging.
Okay. Thank you.
The rolling stroke. Some patients, that's what they've learned. Brush in the direction your teeth grow. The rolling stroke is great because you're massaging the gingiva, you're massaging from the gingival margin and the tooth. You're getting the tooth. So you're brushing the outside, but you're not getting underneath the tissue. Rolling stroke is good for brushing your teeth, not for brushing underneath the gum tissue. And the Charters method. The Charters method, when would you use something like this? Look at this, B, okay? This is A is Stillman's. B is Charters. It's in the opposite direction. When would the Charters be good? The Charters method is good. Think about braces. They have to get on top of that bracket. So not only are you teaching them how to get underneath the bracket, you have to teach them how to get on top of the bracket. And that's where that ortho brush is supposed to be good, because they scooped out these centers. So you're brushing more horizontally. But Charters method is good for that. It's good for if you've got larger embrasure spaces and you don't have an interproximal brush. So it's at a 45-degree angle towards the occlusal plane versus a 45-degree angle towards the gingiva. Now, we say 45-degree angle. Does that mean our patient needs to know it's a 45-degree angle? Absolutely not. Absolutely not. Some methods you're going to tell the patient, instead of the Stillman's, which is coming up like this, and then angling, sometimes it's you're telling the patient to just hold the brush perpendicular and then angle it just a little bit towards the gum. So whatever works for your patient. Charters, think about a big bracket here. Charters also, if they've had periodontal surgery and you don't want to interrupt sutures. Horizontal or scrub methods, you want to see what the patient's doing first, because a lot of times what they'll do is they'll just go back and forth, back and forth, back and forth in one area. Okay, That's great. Do you need to say, well, now I'm going to teach you how to do the Bass method? Absolutely not. You see what the patient's doing, and then you try and modify their technique. Okay, I can see that you're doing a really nice job of brushing your teeth, but what you're not getting, because you've used the disclosing solution, can you see that the purple is right along the gum line area? So, and I can see the biofilm is in between the teeth. Okay, so that's showing me that the bristles are moving too fast. And what you want to do is shorten that stroke to allow those bristles to shimmy in between the teeth. So you're not starting the patient all over again and having them learn new techniques. I would go in and show them my Bass method, okay, to get the bristles to go along the gum line area. And then when they're all done, they can use whatever brushing technique they want to use to clean their teeth, as long as they're not damaging anything. So a lot of times what studies are showing, instead of combining the modified Stillman and the modified Bass, where you've got that rolling stroke incorporated into it, because what you're doing is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 sweep. You're only doing one sweep before you go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 sweep. So some patients are better just doing the gum line area and then brushing their teeth. Okay, so Fones. Oh, circular. Fones, circular. Who would be good at doing circles? Kids. That's what you're teaching kids. Now, the difference with the circle with the Fones is that the patient has their mouth closed. They're biting, okay? And so they're doing the top teeth and the bottom teeth. Okay, so they're doing top teeth, bottom. They're coming like this versus doing the top teeth and then doing the bottom teeth. So we teach the Fones method to kids. So if you've got a 4-year-old in the chair, you're still doing OHE, and you still need to describe what you're doing. So you can see that this is the occlusal area here. So they're doing top and bottom, top and bottom. So what is this not good at brushing? The linguals. Can't get into the linguals. It's not good for interdental cleaning either. It's just doing the large, flat surfaces of the teeth. Leonard's or vertical. I've never seen any questions on Leonard's or vertical. We'll show you that when we get into our OHE clinic. Then we've got our power brushes, which we've gone into. Power brushes, no matter what the brush is, it's basically you hold it in one spot for a count of 3. 1, 2, 3, then move it. 1, 2, 3, then move it. 1, 2, 3, and you let the motion of the brush do the work. A lot of patients still want to move it like a manual toothbrush, and that's not allowing the bristles to do the work for you. So we brushed our teeth. We have to remember to do our occlusal surfaces as well. So with that, that's a short back and forth motion. Okay, again, not doing that whole quadrant or sextant at one time. Wiggle, wiggle, wiggle. What type of adaptations do you need for your patient to get those hard to reach areas? Third molars, partially erupted third molars, lower anterior crowding, teeth that don't have an opposing tooth to it. You're really customizing. what the patient is doing. Okay, occlusal brushing, short, short, short. All right, to let those bristles shimmy into those pits and fissures. Sometimes using specialty toothbrushes work as well. There's something called an end tuft, which is just about that big of a toothbrush there that gets around hard to reach areas, but you want the brush small enough that they can angle to get everywhere, if at all possible. Anterior, okay, this is the vertical brushing. This is great for the anterior facials. If they've got a tooth that is lingual verted, like this one, if you're holding the brush flat, you're going to be missing that tooth. So you hold it up and down. Tongue cleaning, very big. I would have my tooth mug on a shelf, and I would collect tongue scrapers everywhere I went. If they had a different tongue scraper I didn't know, hadn't seen before, I'd get one. Whole Foods was really good at having all sorts of different tongue scrapers, and I've got the ones that I like. But as long as the patient's taking care of their tongue, it doesn't matter. So tongue scrapers have been shown to get rid of a lot of the microorganisms on the tongue. Halitosis or bad breath seems to be stemming from the distal third of the tongue towards the back of the throat. All right, we've got to clean off that carpet. So we've got a tongue scraper. All right, now this is one of the metal ones. And this one has smooth edges. Some of them have tiny little scallops going around. And I like the ones with scallops. I've got a little plastic one, okay? And these kind of act like a rake. But tongue scrapers have been shown to be able to get further back without gagging than a toothbrush. So if you've got a gagger that can't clean their tongue effectively, tongue scraper might work for them. Also, the gag reflex is less at night, so maybe they could do their tongue scraping at nighttime versus first thing in the morning. Lots of different tongue scrapers. Guidelines for toothbrushing. You are going to be helping your patient come up with ideas for trying to brush. So for me, I like the counting system. It just works for me. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Until they get a feel for how long that is. That's the count system. The clock system. Those egg timers that pedodontists have, it's a 2-minute egg timer or some sort of a stopwatch. The power brushes have built-in timers. They buzz or pause at the end of every 30 seconds. Move to another area of the mouth. Okay, you're done with this quadrant. Let's go to another area. Those are the built-in timers. And now we're coming up with all sorts of mobile applications. We're getting smart toothbrushes that you can use your smartphone with to let you know how much pressure you're placing on the brush, what areas you're minimizing your brushing, where do you need to work more. Toothbrush force. Your brush should always look like a toothbrush, and some offices will have a toothbrush exchange system. You bring in your toothbrush for your cleaning and I will give you a new toothbrush, because some of these, when those bristles are splayed like that, they are being ineffective. Okay, you want that brush to always look like a toothbrush. So Oral-B was the first one to come out with those blue lines in their brush, and those blue lines were color indicators. And when that blue line disappeared halfway down the filament, it was time to replace the brush. Now, this is planned obsolescence with some. About every 3 months, we want you to replace your brush, But if you're a heavy-handed brusher and it takes you 1 month to make the brush look like that, you're going to be replacing your brush once a month. So toothbrushing for special conditions. We're going to be getting more into this in perio, but you want to be able to help your patient debride the area, get the area as plaque-free as possible without injuring the tissue. So after periodontal surgery, they're not going to be doing a circular brushing technique. Okay, they might be doing the charters. They might be using a tooth swab with chlorhexidine on it. Acute oral inflammatory, again, they can't be doing a circular brushing technique. It's going to open up the mouth and start bleeding. It's going to hurt, and they need gentle debridement to condition the mouth first, and then they can start doing more circular techniques. So depending on what the patient is experiencing, you're going to be modifying techniques that you are showing. Same way with dental extraction. You do not want to interrupt that blood clot where the extraction site is and develop a dry socket. So you want the toothbrush to be staying away from that. What is a neutropenic patient? Is anybody following along in the book? So you've got a patient with systemic problems going on, all right? You've got a patient that's on medications. You've got a patient that has immune deficiencies. You have a patient that's on medications that is creating gingival overgrowth or more friable tissues. You have to know what to recommend for these particular patients. Patients can injure themselves. So they need to be aware of what they're doing, and especially if they have gingival recession. If they're a scrubber and they have gingival recession, they're using a medium or a hard texture toothbrush, their gum tissues are going to be continually irritated to the point where they're going to go away. And that's where gingival recession comes in. So when we used to recommend originally a hard bristle toothbrush, because the harder the better and massaging the better, this is what we came up with. It's like, maybe it's not the best thing for you. Hard tissue lesions, if they have frank decay, you don't want them to be poking around in there. But every time the patient brushes, there is some sort of a bacteremia that's going on. That bacteria in the mouth is being introduced into the bloodstream. So you have to be very careful. Are you not seeing my slides?
We are.
Oh, okay. Ari said, are you changing the slides? I'm just seeing that now. So I'm going, oh, wow. Okay, so the care of the toothbrushes. It's recommended that you have more than one toothbrush, one in the morning and one in the afternoon or evening. It's recommended that you keep them out in the open so they can dry. You don't want wet brushes being warm, dark, moist. Okay, so you don't want to keep them in medicine cabinets. You'd like to have them out. You would like to have them exposed to the air. You would like them to be away from the toilet, because every time you flush that toilet, there's going to be bacterial spatter that you're not going to be able to see. You want that toilet lid to be down when you flush the toilet. So ideally, the brush should be completely dry in between. Brush replacement is whenever it starts to splay or show wear. Typically, it's about every 3 months. You want to be able to clean your brush. Some people will put their toothbrushes in the dishwasher. Some will put peroxide on it. Some will rinse it with mouthwash. But you want to be able to clean your brush, get all the toothpaste off of it, tap the brush against the sink to get a lot of the water out before it starts sitting and trying to dry. After a cold, after an aphthous ulcer, after herpetic lesion, you want to change your toothbrush, because that bacteria or the virus stays on the brush and you can reinfect yourself. Right, so all of this was just about toothbrushing, and it's important that, again, that we have the same language that we're talking to our patients about, so it's we're all knowing what one person is saying to the other. This is really hard when you've got multiple hygienists in the office and somebody's only doing one thing. I'm only recommending the Sonicare and I'm only recommending the Oral-B. There can be some differences there. Well, Susie said the Sonicare is better than the Oral-B. Well, it all depends on what's best for your mouth, right? Document, document, document. Right, so all of this is about teaching the patient. And that's what your OHE book is going to help guide you with. Are there any questions? Okay, let's take a break. I've been yakking. Let's take a break. We'll come back. I've got 9:17 on my phone. So let's come back at 9:30 and we will continue with interdental care. Any questions? Okay, bye guys.